My name is Paul Ridker. I direct the Center for Cardiovascular Disease Prevention at the Brigham and Women's Hospital in Boston, and I have the honor of serving as the Eugene Brownwell Professor of Medicine at the Harvard Medical School. On behalf of the American Society of Preventive Cardiology, I'll be talking very briefly this morning about moving beyond LDL cholesterol reduction and toward universal screening for inflammation, universal screening for high-sensitivity C-reactive protein. Very recently, my colleague Giovanni Liuzzo and I wrote an editorial for the European Heart Journal, arguing that universal screening for hsCRP has come and is a major therapeutic opportunity for us in preventive cardiology. Our editorial made two main points. First, high-sensitivity CRP, a biomarker of silent vascular inflammation, is at least as strong a predictor of future cardiovascular events as is LDL cholesterol, and that's true in both primary and in secondary prevention. And second, the clinical dilemma. Doctors simply will not treat what they don't measure. We need universal guideline recommendations to screen all patients for high-sensitivity CRP, just as we screen for cholesterol. What's the data for this? Let's start in high-risk secondary prevention. 2 years ago, we published these data in The Lancet looking at 3 major clinical trials, PROMINENT, REDUCE-IT, and STRENGTH. Overall, 31,245 secondary prevention patients, looking at many different cardiovascular endpoints, here in particular cardiovascular death. And you can see in this graph that the black bars, the high-sensitivity CRP levels, are a much more potent predictor of cardiovascular death than are the white bars, LDL cholesterol. Now, all these patients are already on statin therapy, and I'm a very aggressive LDL-lowering physician. But the message here is that among patients who are taking statins, and we've shown this among patients who are not taking statins, inflammation is the next target that is yet to be addressed aggressively. Just last week, my colleague Gabrielle Steg published in Circulation similar data comparing LDL cholesterol in blue, CRP in the red, and Lp(a) in the gray, showing that, again, these 3 markers all predict risk of MACE as well as all-cause mortality. This happens to be a study of, again, secondary patients following acute coronary ischemia, also on high-intensity statin therapy. There have been 4 or 5 papers like this, highly consistent. I now want to shift over to primary prevention. Last December in the New England Journal of Medicine, we presented a very large study of nearly 28,000 initially healthy women followed over 30 years. I'm comparing here the predictive value of a single random blood draw for hsCRP on the right in quintiles to LDL cholesterol in the left on quintiles. Now, both are very powerful predictors of risk, but notice that the spread, the distance between the low levels and the high levels for high-sensitivity CRP is actually greater than that for LDL cholesterol. And many of you, of course, have concerns that hsCRP has variability, but variability is a bias towards the null. That means the importance of inflammation in primary prevention is actually greater than is already being shown in this slide. This is a comparison, again, of hsCRP on the right to Lp(a) on the left. Again, many of you are considering screening for Lp(a) once in life. Once again, the data for CRP are even stronger. What's most important from my perspective, however, is to measure all 3 of these biomarkers. Patients have different reasons for having chronic risk. It's not a one-size-fits-all issue. So as you can see here, for individuals with 0, 1, or 2 elevated biomarkers, in other words, we simultaneously measured CRP, LDL, and Lp(a), we're learning a great deal about those who have all 3, and we have therapies for those who have any one of these particular 3. Now, we've just published very exciting data that fully replicates these American data, but now in a European cohort of both men and women. You can see on the left, again, 20-year outcomes for LDL cholesterol, in the middle, 20-year outcomes for high-sensitivity CRP, and on the right, 20-year outcomes for Lp(a). And once again, if you have elevations of all 3, 2, or 1, issues are different. We think the time has come for screening of universally for these 3 biomarkers. Now, I'm often asked, what can we do about this? LDL cholesterol, we can put patients on statins. We have further LDL-lowering drugs. As long as we're thinking about inflammation, this is a great way to reinforce good primary prevention, healthy diet, smoking cessation, exercise. And I want to point out here this lovely quote from my friends Annette Christ and Ike Lotz. The Western diet appears to be mistakenly recognized by the immune system as a threat to the organism, data that came out with the Predimed study many years ago. We also have evidence that statins should be given to patients who have elevated levels of high-sensitivity CRP who do not have elevated levels of cholesterol. That data came from our Jupiter primary prevention study published in 2008, demonstrating very large reductions in risk if patients received statin therapy, in this case rosuvastatin, despite having low levels of LDL. So we already know we have a therapy in that respect. Finally, and very relevant to the audience today, there are multiple anti-inflammatory drugs in development: canakinumab, an IL-1 beta inhibitor, ziltivekimab, IL-6 inhibitors, colchicine, low-dose methotrexate, IL-2 inhibitors, IL-1 inhibitors. Many different types of therapies are coming that will help us to address whether lowering inflammation per se lowers risk. And of course, we have many therapies that will help us to lower Lp(a) in ongoing clinical trials. The point I really want to leave you with today is very simple. Residual inflammatory risk is at least as important as residual cholesterol risk. The time has come for universal screening, and once again, physicians will simply not treat what they don't measure. We've known for a long time that knowledge of LDL, high-sensitivity CRP, and I also believe Lp(a) can tell us a great deal about which patients are at risk and who might we treat. Thank you for your attention.